In this segment, the role of the urologist in establishing an advanced prostate cancer clinic will be discussed. Diagnosis and clinical management of castration-resistant prostate cancer using newer oral agents and related bone health issues in patients with advanced prostate cancer will be covered. Best practices for optimal use of imaging modalities and laboratory testing for patients will also be reviewed. So we all know that basically over the past 5 years with all these new therapies, it really started off, if you think about it, it started off with the approval of denosumab for SRE prevention. Then it quickly progressed to a number of therapeutic interventions in the CRPC space. So Neil, you, without a doubt in my mind, you have been one of the biggest champions in this space over the past 4 years. Tell us a little bit about, because I remember sitting at meetings with you 4 years ago and you were talking about, hey, we need to be involved in this. Why do you think it is so important for the urology community to be involved here?
Well, I think that first and foremost, it's about advancing the benefits of patient care. And we now have therapeutics that we can really improve not only the longevity of our patients, but the quality of their lives. And we can do it in a way that's cost effective. And we do it in a way that gives vitality to our specialty. And it should give vitality to our specialty as urologists that's not detrimental or internecine regarding our colleagues, whether they be medical oncologists, primary care physicians, radiation oncologists. We can all work collaboratively and keep in mind, and I don't mean to be too namby-pamby about it, but it really is about doing what's best for the patient. Looking at our specialty and making sure we don't become marginalized to just surgical technicians, but true overarching caregivers of urologic care. And even though we've had tremendous improvements in device technologies, and will continue to do so, the cutting edge science is in understanding proteomics and genomic pathways so that we understand how to better diagnose, better predict, better prognose, and better treat. And that's going to make us as urologists that much better. And I think that's really the kind of the overarching theme to why we need to be doing this.
Dr. Cheatham, so you are in an academic institution. Obviously, that model of care is different. It's not better or worse. It's different from what many of us practice in. So at Winthrop, so how are you guys evolving that? How are you getting involved with the medical oncologists, the radiation oncologists, your nurse navigators, et cetera? How are you trying to make all that happen?
The first comment I would make, Raoul, is that I was never comfortable with this concept that when the patient progressed, that they went into this magical, mystical world of medical oncology that we as urologists did not really understand. The patients still come back, they're asking questions about their treatment when they're under medical oncology, and I think the time is right that we need to own this, that we need to be educated, that we need to educate our patients, that we need to do our best to keep up with these advances, and that we need to work together. At Winthrop, we're all on the same site, the medical oncologists, the radiation oncologists, the urologists. We're in a very tight-knit area geographically, which can certainly help. We have strong relationships with the radiation oncology. They're also offering RAD223. The medical oncologists are very keen to work with us. We're offering Provenge in the setting. We have integrated our nurse navigator between those three departments, which certainly helps with communication and to set patients up in a timely manner for medical assessment with different specialties. We also discuss these cases very openly in our tumour board and have an academic discussion, not just about the individual patients, but also the new research that's coming out in castrate-resistant prostate cancer. So it works well. We engage nurse practitioners. We have a physician's assistant who helps us with the day-to-day setting up of Provenge and monitoring patients. But I think that more and more we're going to have dedicated time to spend with these patients, and I think moving towards a clinic where we can actually see the patient in the same room at the same time can certainly benefit.
So Ken, you've got a 50 plus guys now, multiple offices. Again, a complete 180 degrees from Dr. Cheatham and her setup, even different from Neil's, you know, somewhat more akin to mine. Sure. But so how do you guys at MIU, how do you guys bring all this together?
You know, it's a process, like Neil says. You know, I remember when I first went to the group and said, you know, we need to think about bone health and start infusing Zometa. It was like a revolution. How can we do that? I said, you know, we need an IV pole and a chair, and I think we can do this. And it was just changing that mindset, which again, in a large group or even in a smaller group, sometimes it's like steering an aircraft carrier. It takes time to make that change. And then what we did is we decided to centralize and started with bone health. That seemed to be the place to start. So we centralized that with a nurse practitioner and then referred those patients in for their bone health treatments. Now we've since spread those bone health clinics to multiple different offices geographically. We've really kept our advanced prostate cancer clinic, though, centrally located, and that's one of the offices, my main office. And so we give Provenge there, we do all the advanced therapies there, we counsel patients there, and that's really been the central location. So, and I think people understand that hey, you know, you're going to go, just like going to a university setting for your treatment, you're going to stay within the group, you're going to see one of my partners who specializes in this, you'll still see him, but he's going to provide this extra care. Again, with nurse practitioners kind of going along the way to help those patients. And again, education is really key to the patient.
I mean, I think what's clearly happening is that, especially for those of us who practice in the large group setting, to me, you know, I kind of term this buckboard medicine. It doesn't make a lot of sense for 30, 40, 12 guys to all doing the same thing. It just makes no sense to me. I think people are aware, the JOQ public is aware, you do one thing, you do it well, you continue to do it, it's repetition, repetition, you get better results. Now, part of that, I think, whether it's in the hospital setting, whether you have the same OR staff, you have the same people on the floor, in our setting for this particular patient population, it is again having a physician champion, but also the ancillary support of the same nurse who does all the paperwork, whether it be for Provenge, whether it be for the specialty pharmacy, whether it be working with the foundations for patient assistance. So again, I think that model, physician champion, nursing champions, extenders, those types of things. Mike, the question really is though now, how do you get your partners to buy into this? Because again, depending upon your distribution formula, how you're paid, whether as we talked to our friend Van Kasabian, whether you're communist for capitalists or you're strictly on productivity, how do you get your partners? Because all of us are surgeons, you know, we think that we can do everything great. You know, the old joke is if you ask a surgeon who are the best three in his area, he doesn't have any problems naming himself, it's the other two guys. So, how do you get people, how do you get your group motivated to say, you know what, Mike Williams is going to be my go-to guy for CRPC?
That is a difficult model. I mean, it is. Within our group, you know, it's merged over several years. You know, we started off in the department there has been present for about 50 years or so. And over time, it's increased and grown. And as you've added new people, it's become everyone was doing everything. But eventually, it became to where subspecialization was the name of the game. We have people that subspecialize just in management of BPH. We have infertility specialists. We have our lap donor nephrectomy program that just is subspecialized within a certain group of people. And just like that, we have 3 of us that are just urologic oncologists that do all of oncology. So in that aspect, it became very easy. You know, we could just train them. It's getting them to understand, however, that now with so many new options available that we can actually do, that they no longer need to just have that hair trigger pull to send to the medical oncologist, just to get them, hey, we'll see them, we'll take care of them, we'll get them managed. And getting that referral base back within your own practice was the biggest step, honestly. That takes time, and for us, it's been quite successful.
And I also think it's important from a standpoint of trying to get our partners, ultimately it's about the patient, right? So it's a win-win for the patient. The patient gets better care. And I also tell some of our partners who are kind of dabbling in advanced prostate cancer, like I don't want to dabble in, you know, pelvic floor reconstruction, incontinence, things like that. it's better for us too. So, you know, it's not, seeing these patients takes time. You know, you need to have that commitment. So, you know, if you let that patient go to one of us who are the champion, it's better for the patient. It frees you up to see more patients that you like to see. So again, I think it's a win-win for everybody. I think that's the educational component to our partners.
And I think